scientific program of the first annual international conference held in Lahore, and this time it was held in Karachi, and the program was absolutely marvelous. It was wonderful, and we have received so much appreciation, and this is continuation of that. Usme I am glad that our students have joined in, and our residents are also here, and the faculty, and Professor Aziz Rehman is known for his style and his slides and his impact factor. एक impact factor होता है जो जर्नल में काम पब्लिश करके होता है. उनका जो impact factor है जर्नल वाला तो है ही, लेकिन जो पढ़ाते हैं it impacts the students greatly. So I'll welcome him and I will request you, sir, to start the workshop. Thank you.
Thank you, sir, for very generous and very kind words. Our third national conference was undoubtedly a huge success, but I think you deserve most of the credit because you are the chairman of the organizing committee. We were actually working for you, and that made it successful. This is actually a workshop. That means there will be a lot of interaction. I hope you are ready for interaction. It consists of two parts. In the first part, I will discuss the basic principle, the theory part. I will restrict myself to the level that you need to know and the level that I actually know. But in the second part, which is based on case scenarios, so if you understand the first part well, then the second part should be very easy. So I would certainly like your input in the second part. It will be in continuation actually. So let's start. I start with this one? Okay. So this is the agenda. Looks quite rich, but it is actually very brief. First, we will discuss what is Hba1c or glycated hemoglobin. Then its diagnostic value in diabetes. Then its monitoring value, again in diabetes. There are some limitation of the test. There is nothing in this world which without limitation or without the downside. This test also has some limitation. I would highlight those because you have the right interpretation of the test. Then case scenario. First of all, what is Hba1c? Very briefly actually. This is our RBC. RBC is nothing more than a balloon full of hemoglobin. About 99% is hemoglobin, very thin membrane, rest of it is hemoglobin, no organelle, no nucleus. So it's basically just hemoglobin. And you know, there are three types. There was hemoglobin A, the adult type. Then we discovered hemoglobin A2, which is slightly different. And then the hemoglobin A was renamed as hemoglobin A1. And then hemoglobin F, which is hemoglobin which is present in fetus and the high concentration. Even in adults, we have it in small quantity. Now, all are hemoglobins. When we measure hemoglobin, when you order HB, all are collectively measured and we have total value. But most of it is Hba1, which is the main type. And you know, we also have this glucose in the blood. All of us, whether you are diabetic or not, if you're healthy, even then you have a certain level of glucose. So glucose and hemoglobin, particularly hemoglobin A1, are circulating in the blood, both in their required concentration. Now they can get glycated. What is glycation? It is actually an irreversible, now this is important, irreversible but non-enzymatic binding of a glucose molecule with N-termin of beta chain of hemoglobin A1c. A little tricky, but it is a non-enzymatic binding. That means the process is slow. But it is irreversible. Whatever glucose is bound to hemoglobin, it is not going to detach. It is going to stay with that RBC till that cell dies. After his life, that is about 120 days. And it is attached to the N-terminal of beta chain of hemoglobin A1c. That means if there is a hemoglobinopathy or some thalassemia which affects beta chain, that is going to affect our Hba1c also. So although we have Hba1a and Hba1b and Hba1c, but majority of his Hba1c, there are different patterns. Actually Hba1c, the glycoprotein, glycohemoglobin, which is of subtype C, is the predominant. When we say A1c, sometimes some laboratories actually they measure total glycated hemoglobin, they just call it Hba1c. So that is why there is some disparity in the reports also. But when we say A1c, that means the glycated hemoglobin A1 subtype C, which is of clinical importance. Now this is an RBC, which is like most of it still hemoglobin, but some glucose. Now interestingly, when this glucose binds to the hemoglobin molecule, it does not affect the function of hemoglobin. Hemoglobin continue to function as hemoglobin, and it is chemically the same, but there are certain ways of differentiating this glycated hemoglobin from normal hemoglobin, and that provides the test value. Now this RBC, on the right side, which is mostly hemoglobin with little bit of glucose, and the amount of glucose is proportional to the amount of glucose in the blood over that period, over the life of that RBC, and this cell is going to live approximately 120 days, and that is how long this glycated hemoglobin is going to stay in the blood. So this is non-enzymatic but irreversible glycation, and it is going to stay in the blood as long as this RBC persists, RBC survive. Normally in most people average RBC life is 120 days, but it could vary. In some cases it may be longer, in some cases it may be shorter. So that is how this could actually affect our hemoglobin A1c. Now these are the units. On the left column we have DCCT Hba1c, which is expressed in percentage, and this is widely used still in Pakistan, and this was used by the DCCT trial. But these days International Federation of Chemistry organization, they have suggested this different value. They said this should be expressed in millimoles per moles. What is the rationale behind? Because it actually blows up, it expands the spectrum, it gives you the better spectrum. In Pakistan we are still following this percentage. In some countries they are giving dual values, percentage as well as millimole. Some countries have converted into millimoles per moles, but we are more familiar with the left column percentage. Now you can actually calculate the average glucose. On the right column we have EAG. EAG is estimated average glucose from Hba1c, right? So if you have somebody's Hba1c, you can have an idea how much the average glucose in that patient over that period of time. Why this conversion? 7, I think 7 is our goal. You might think 7 is great, but when we convert into average glucose, that is 154. That is not at all ideal. So I think you get better impression of glycemic control when you convert Hba1c into average glucose. So that 154, which also includes your fasting. So to me 154 looks quite bad, whereas 7 looks quite all right. So that is how you can convert. We have formulae available. There is a formula I've given you. If you want to calculate yourself, there is an equation given, but you have these apps available online. I think you can download any of those and you can very quickly convert. Many laboratories in Pakistan also, they are giving. In fact, they are probably under binding. In some countries at least, they give A1c and then they give average glucose also, the calculator from the app. So we're done with, very briefly I said, what is hemoglobin A1c and all the diagnostic value. You know, you may be surprised, till 2010 it was not used for the purpose of diagnosis. It was only used for the purpose of monitoring how bad or good glycemic control is. So only in 2010 it was introduced as a diagnostic value. And for example, if your Hba1c is less than 5.7, excluding 5.7, if your value is less than 5.7, you are normal from glucose point of view. And if it is 6.5 or above, including 6.5, if your glucose HbA1c is 6.5 or above, you are unfortunately diabetic. Now, irrespective of fasting, non-fasting, morning, evening, whatever time. So if your one single value is more than 6.5, you're diabetic, and if your value is less than 5.7, you're okay. But if it is in between, this is a new category called pre-diabetes. 5.7 to 6.4 is pre-diabetes. This is actually diabetes in the making. I always tell my patient, this is not a very benign condition. You are just few kilometers away from diabetes. You are going to develop diabetes if you do not adopt a healthier lifestyle. So this is the diagnostic value. As against glucose, although we can use glucose also for the diagnosis, fasting glucose, you know how much is normal, how much is abnormal, what range is pre-diabetes, but that is subject to fasting and feeding. So this can be done at any time. Also the point of care. So this is the diagnostic value. One single value, you know what is your status, normal, pre-diabetes or diabetes. Now let's talk about the monitoring value. This is where it is, I think, very, very popular. Done every 3 months before a visit. I typically call my diabetic patient for a visit after 3 months and ask them to have a fresh Hba1c. Now 3 months is a reasonable time for a next visit also, and just to make sure that things are going well, and 3 months will also give you the value which would reflect the 3 months treatment plan the last 3 months. So I think every 3 months you can have the test, provided patient's glucose values are also normal. Now be particular about the lab. I never tell my patient to go a specific lab because people interpret in a different way. They think that I might have some incentive. But when it comes to Hba1c, even in America, all laboratories are not standardized for doing Hba1c. It's a very tricky test. So I think you should give a face value. You should trust a laboratory, the lab test which comes from a good lab and the good, I think, your own criteria. Many times I've seen discordance between sugar and Hba1c, and when we repeat, Hba1c is actually was wrong, really reported. Now, does not replace blood glucose monitoring. Please do not take the impression that glucose monitoring is not important. Self-glucose monitoring is very, very important, and I'll show you what is the place of glucose monitoring and Hba1c. May not be done if blood glucose values are high. Now, you could actually have different opinion. We want to know the glycemic status. If somebody has his sugar values, he comes to you and he shows you 2 or 3 reports showing blood sugar of 230, 300, then I'm sure you're not going to get any additional information from Hba1c because you already know that your patient's glycemic control is pretty bad. So I think that will be, based on money. So that is not the right place. May not give reliable value if patient has some blood disorder, particularly thalassemia, hemolytic disorder, recent blood loss, recent blood transfusion. In all these conditions, you should be cautioned about the importance of Hba1c. Now this is the strengths and weaknesses comparison of common monitoring tests. Now I have just listed 3, there are more actually. Plasma glucose, self or lab test, plus minus 10%. Now according to international standardization, if your glucose, this glucometer estimates your sugar 10% plus or minus, it is considered to be accurate. Then Hba1c could be done in the laboratory mostly. We do it in the laboratory, but point of care test is also available. That means in the clinic, just like glucometer, you can test Hba1c also. Then the last one is continuous glucose monitoring, which is actually an expensive device. You can have your glucose checked at any moment. It actually makes a graph, records, but this is very, very expensive. Now, what is the value of plasma glucose? it gives you instant value. You want to know your glucose now, if you test, that will give you your current value. It can detect hypoglycemias. A1C seems to be a great test, but it cannot detect hypoglycemias. So it will detect hypoglycemia, which is very, very important. In the long-term management of diabetes, hypoglycemia is very important. Then adjustment of medication. Somebody has normal sugar in the morning, but high in the afternoon or high at night. It tells you which dose, which medicine, which pill is to be increased. And cheap and readily available. So this is the strength of plasma glucose. Whereas Hb1c gives you an average value, just one test will give you 3 months average. It is meal independent. Whether the patient has taken meal or is fasting, it gives you the same value. And one value is diagnosed. So you don't have to repeat the test. Glucose tests, many times you have to be repeated because patient's fasting was not for 8 hours or patient is going through some stress. So I think A1C, just one value and some caveats that I'm going to discuss later. In continuous glucose monitoring, multiple readings per day. It is not exactly continuous glucose monitoring, but we have something called Libre. There's a device which we can attach. We can have value when anytime you want to have it. It is not going to make a graph on the computer, but you just attach the device and it gives you. But it's fairly expensive, 24,000 per month. More accurate averages and useful in type 1, because in type 1 glucose fluctuates very rapidly. So we would definitely like to have continuous glucose monitoring devices in type 1 diabetes patient. It is expensive and tedious. So usually, I guess plasma glucose and A1C both are useful. For routine purposes, plasma glucose, patient can, whenever patient suspect he is going through the hypoglycemia, get check sugar, whenever he feels that he is overeaten and he taken a lot of carbohydrates, can check sugar, and then A1C at the before visiting. Now, this I just added when I was coming to this place. These two tests, 1,5 and hydroglycitol, abbreviated as 1,5-AG glycomark. This is an FDA approved test, but never became popular. Two people can have same A1C. One may have more glucose variability, other may have less glucose variability. The one with increased glucose variability can be differentiated from another person with less glucose variability with the same A1C by this test. I will not go into the detail. Then fructosamine is like glycated fructose. It can be used when you cannot rely A1C, like for example beta thalassemia, or when you need to closer monitoring like in pregnancy. Now what is the goal? Goal is to get everyone to less than 6.5. This is American College of Clinical Endocrinologists and International Diabetes Federation. So everyone with diabetes we should try to achieve less than 6.5%. ADA and ESD say that for majority 7 is good, but those who do not have comorbidities, those who are young, there we should definitely try to achieve better, which is 6.5 or 6. And then ACP, the American College of Physicians, they say getting below 8 is very, very resource intensive and is prone to cause hypoglycemic complication. They have given their recommendation and they have published it that even 8 is good enough for majority. So I don't, most of the people, they do not feel comfortable with this one, although in real life, most people, they have their average A1C 8 or above. But I think you should make your goal of 7. So this is a diaphragm. Then on the left we have tighter control, on the right you have a lighter control. Those who are younger, those who have a relatively new diabetes, those who do not have too many comorbidities, cardiovascular, less prone to hypoglycemias, more life expectancy, you should aim for tighter control. That means you should make the goal of 6.5. On the right side, the lighter control, older people, long-standing diabetes, comorbidities, prone to hypoglycemias, and relatively limited life expectancy, then you can maybe contend with relatively higher Hb1c. So this is the monitoring of glucose with A1C. Now, limitation of the test. Reliable lab. I think because there are at least, the pathologists know it better, there are at least 4 different methods of doing this test. Now, if there are 4 different methods, of course, they have different level of accuracy and reliability. And they have also different price tags. A good laboratory will probably use the best method and will give you the best value and will probably charge more. And those laboratories which want to offer the lesser price, they will probably use less good methods. So I think reliable lab, and it only gives you average values. Now, just to make this concept important, I just make you this equation. The average of 49 and 51 is 50, right? And average of 1 and 99 is also 50. These are 2 very, very different scenarios. In the first example, glucose variation is very, very, in a narrow range. In the second example, there is a lot of excursion, but the average is the same. So that can actually give you a wrong impression. Rbc lifespan and hemoglobinopathies. If you have beta thalassemia major, you are unlikely to live long enough, and you are unlikely to have diabetes and all that, because most people, they will die in the young, very early age. Beta thalassemia minor, they do have beta chain, only in lesser quantities. So I think in this case, you would probably be underestimating their true glycemic status from the Hba1c, but you will still be able to follow the trend. If the previous value was 8%, now is a 7%, you at least know that glucose is getting better. And there are some nomograms available. You can correct the change for the given person. Another person who has recently received blood transfusion or has got hemolysis or got vitamin B12 deficiency, there also I think A1C may not be very reliable. But if you know those conditions, you can make appropriate adjustment. Does not detect glucose variability. It gives you the average. So now the case scenarios. So now your input would be, can we identify a person before I give you the first scenario? Can somebody volunteer to take up the first scenario? Younger the better. All right, so you take this to them. Who would volunteer? The first one is the easiest one also. Please volunteer someone. All right, please stand up. Can you come here? Come here. An asymptomatic 38 years male comes for your opinion after having following test. His weight is 78 kg, BMI is 29.7. Blood sugar fasting 8 hours overnight, 112 milligram per deciliter. Blood sugar random 2 hours after starting meal, 130 milligram per deciliter. Hba1c is 5.4%. Right, the question is, what will you tell him that he has? What would you label him? Is he normal, or would you give his condition a name? Idhar.
Sir, I think the patient is pre-diabetic.
He says the patient is pre-diabetic. Okay, very good. Pre-diabetic also has got 2 categories. Which one is this?
I just know that it is a pre-diabetic, not definitely diabetic. He is prone to diabetes.
Right. This condition is called, anybody? (112 milligram per deciliter), 8 hours overnight fasting is not normal. दोनों की अहमियत है, Hba1c की भी अहमियत है, इसकी भी अहमियत है. You can't disregard blood glucose. There is a condition called impaired fasting glucose. प्री डायबिटीज का मैंने बताया, प्री डायबिटीज के अंदर दो है, एक इम्पेयर्ड फास्टिंग ग्लूकोज है, एक इम्पोर्ट ग्लूकोज टॉलरेंस है. तो ये इम्पेयर्ड फास्टिंग ग्लूकोज, ठीक है ना? ओके, गुड. सो योर आंसर इज करेक्ट एक्चुअली. नहीं अभी आओ. What should be done? Would you give him some advice? Would you put him on medication or what?
Sir, as we can see, the BMI of patient is very high. So
He has identified this patient has got impaired fasting glucose and the guy has got high BMI, 29.7%. BMI is high, he should be advised on lifestyle. This is pre-diabetes. This is surely going to become diabetes if nothing is done. So I think best advice at this person, don't be very happy with the 5.4. Probably he has developed this dysglycemia only recently, right? So I think you should take action on 112, although you need to have 126 and above to be diabetic, but this is pre-diabetes, impaired glucose, impaired fasting glucose. Thank you. Can you now identify another person who will take the next question? Your friend or your enemy or whoever.
Surrender your right.
Please volunteer somebody. Thank you very much. Good input. Did you raise hand? No, I'm not going to proceed unless somebody. Fiza है ना? नहीं, हाँ, Faika, okay, sorry. All right. Case scenario 2. A 49 years old known diabetic and on regular medication comes with the following recent reports. Fasting blood sugar ranging between 140 and 200 milligram. He has got multiple readings with his own glucometer. Blood sugar random ranging between 180 and 290 milligram per deciliter. Again, multiple readings. The question is, how crucial is Hba1c testing to decide the next treatment course in this patient? Either out. नहीं इतना अंदर रोस्टर पे इसकी तस्वीर आएगी. Okay, how this case scenario, right? How crucial is it? Is देखो, this is बेहतर नजर आता. How crucial is Hba1c to decide the next treatment course in this patient? Now you have to take a decision right away. Do you think Hba1c is crucial?
No, sir.
No.
Not
Why
really.
not?
Sir, the readings for to diagnose diabetes in the fasting range are well above 125 in this
Excellent. So common sense. Very good. So glucose values are already so bad. You know that this guy is diabetic, and at this moment, I think you can make a decision. You could still do Hba1c just to have the baseline, and then whatever treatment you give, and then you repeat the Hba1c after 3 months. That might be useful. But the first action, just to label him diabetic and to start medication, you don't need Hba1c at this stage. There's another one also. Okay. What would be the best time to have his Hba1c repeated?
3 months after once he has achieved stable glycemic control.
Very good. This is also, I think, second part. She's very rightly added. Thank you. If I think not earlier than 3 months. Best is after 3 months. I think even then, if he has failed to achieve his glucose values, then A1C again is not going to be very useful. Best is that he monitors his sugar maybe once a week, fasting sugar, and they are quite pretty okay. And then to make sure that his blood sugar is actually controlled throughout the day and throughout the week, then further A1C would, I think, be very good. If sugar value is okay, A1C is also at the goal, that would mean that you have achieved your goal. So that is the true value of case scenario 3. Somebody from Sadaf, आप identify कर दो किधर कोई? आ जाओ please, आ जाओ शाबाश. You get the chance of coming to the rostrum. आ जाओ. Okay, the scenario is a known diabetic for the last 10 years on oral anti-diabetic therapy comes with the following as. He is diabetic for the last 10 years. इधर देखो, इधर अच्छा नजर आता है. Non-diabetic for the last 10 years on oral anti-diabetic therapy comes with the follow-up. Hba1c is 6.9. What do you think? Is it okay?
No.
6.9 for a person who has been diabetic for the last 10 years. 6.9 is pretty okay.
Yes.
Okay. Blood sugar fasting is 112. Fairly okay. I think to me it looks quite acceptable. Serum creatinine is 1.2 milligram per deciliter. eGFR is 90. The question is, urine complete examination reveals 2 plus glycosuria, and the person is a little worried, and he says, I still have this lot of glucose in my urine because he used to follow glucose for the glucose monitoring, and no sediment. Otherwise, urine microscopy does not show any problem at all. It's just 2 plus glycosuria, okay? You know the blood sugar, you know the A1C, and you know the 2 plus glycosuria. Now the question is, would you readjust his medication in view of his glycosuria?
Yes.
Glycosuria reflecting poor control, would you consider the glycemic control is not good, and would you like to make some adjustment?
Yes.
Or would you look for some other explanation of glycosuria?
Some dietary lifestyle modification and dietary adjustment with medication. We can commence in.
अगर उनकी शुगर नहीं कंट्रोल तो फिर उसका ब्लड ग्लूकोज ज्यादा है ना. देखिए, यू स्टार्ट pouring glucose into the urine once your glucose exceeds 180. हाँ जी. और उसके बाद भी जितना ज्यादा बढ़ जाता है, फिर 2 प्लस ग्लाइकोसूरिया के ऊपर ब्लड शुगर होनी चाहिए 250. उतनी बिल्कुल भी नहीं बन सकती है बंदे की. Can you think of some other possible cause of glycosuria with normal glycemic control? He is on oral anti-diabetic therapy. Is there any diabetes medicine which causes glycosuria? Which one? Anybody? Is there any medicine which gives you very good control? इतने बड़े क्राउड में किसको पता? फैसल, आपको नहीं पता? SGLT2 inhibitors. SGLT2 inhibitors, उसका काम ही ये है कि ब्लड में से ग्लूकोज को यूरिन में फेंकना है. वो ग्लाइकोसूरिया करती है, तो मैंने 2 प्लस लिखा है. नॉर्मली सी 4 प्लस ग्लाइकोसूरिया विद नॉर्मल ग्लूकोज कंट्रोल. पेशेंट को चुके उसके क्वैक्स ने या उसके पुराने फिजिशियन ने बताया कि ग्लूकोज नहीं आना चाहिए पेशाब में, वो वरीड होगा. सो उसको ये एक्सप्लेनेशन देना है कि ये उसकी वजह से, दवाई की वजह से है. इनफैक्ट आई टेल देम द गुड पार्ट इज दैट योर मेडिसिन इज वर्किंग. राइट. ओके. नहीं, एक मिनट रखो, दूसरा सवाल है. हाउ विल यू एक्सप्लेन द डिस्पैरिटी बिटवीन ब्लड? ये हो गया, मतलब ये हो गया. उसको बताना कि ये दवाई है. You will, if you confront with this situation, you will go through the prescription, and if you find SGLT2 inhibitors, dapagliflozin, empagliflozin, then you will explain this disparity to the patient. Okay? Now another case scenario. Somebody from boys side, please. Aziz. Very good. Aziz, shabash. Half marks for volunteering, half marks for giving good answer. Aziz. Case scenario 4. A 45 years old lady, 85 kg in weight, diabetic and hypertensive for the last 10 years. She has failed to achieve her Hba1c goal with optimal doses of 3 oral hypoglycemic agents. 3 oral optimal doses. हर दवाई की डिफरेंट ऑप्टिमल डोज होती है. जैसे ग्लूकोफेज की 1 ग्राम ट्वाइस ए डे, सल्फोनेरिया में से ग्लैमिपेराइड है 2 मिलीग्राम ट्वाइस ए डे, एम्पाग्लिफोजन 25 मिलीग्राम ए डे. 3 टैबलेट्स की फुल डोज पे है. She has failed to achieve her Hba1c goal with optimal dose of 3 oral antidiabetics. The decision of starting insulin was deferred to the current visit. Now this reflects a real life scenario. On every visit, patient has got bad glucose values. I suggest to them that you need insulin. And in this case, last time it was suggested to her But she said, no, I'm going to try harder, and next day we'll decide. So this visit was actually, it was decided that we were going to decide about the next treatment plan in this visit. Now these are the values. She recently had a road traffic accident and was transfused 2 pints of blood. She is taking her full dose of triple oral therapy. ठीक है? और her current lab blood sugar fasting 170 milligram per deciliter, Hba1c is 6.8 and urine protein 1 plus. This is the question. What is your opinion about starting insulin or the next treatment? Do you consider her current glycemic control acceptable in view of her Hba1c of 6.8, or do you think the plan is not working and you need to put her on insulin or some other agent?
So the plan is working because
working?
she's an old diabetic. The Hba1c is...
Michael.
Sir, the plan is working, not efficiently but appropriately, because the
170 fasting is acceptable.
Oh, sorry. I thought it was BSR. I was
170
looking.
Anji.
No, it's not okay.
So then how do you explain this such excellent A1C?
A1C, sir, because before the accident she could have been controlling it better,
No,
and then due to transfusion of blood,
she received a transfusion from a person who has A1C of
Better
5
control.
because he was because transfusion is typically taken from a healthy younger person. उसकी 5 थी, प्लस उसके दौरान जो उसकी हीमोडाइलेशन हुई, उसकी अपनी जो हीमोपोसिस हो रही है, उसमें ब्लड ट्रांसफ्यूजन के अलावा जो उसकी अपनी रैपिड हीमोपोसिस हो रही है, जो नए आरबीसीज बन रहे हैं वो ग्लाइकेट नहीं हुई, बेशक अभी ग्लूकोज लेवल काफी है. सो दिस Hba1c इज डिसेप्टिवली नॉर्मल.
it's not healthy.
ग्लाइसेमिक कंट्रोल इज नॉट गुड. और 1 प्लस प्रोटीन यूरिक का मतलब है कि देयर इज अ स्टेट ऑफ अर्जेंसी, यू कांट वेट मोर.
Yes, sir.
So I think we need to take action.
Yes.
I will explain this disparity to the person. I still say the plan of oral agent is still not working. You probably need to add another agent. Or would you rather consider some other therapy? और या इंसुलिन ही जवाब है इस कंडीशन का.
सर इस वक्त तो इंसुलिन ही रहेगा क्योंकि रेगुलर इंसुलिन स्टार्ट कर
हाँ।
दिया.
और वैसे सोचो जरा आउट ऑफ द बॉक्स, इंसुलिन के अलावा कोई है चीज जो यहाँ कंसिडर हो सकती है. आजकल दुनिया में वैसे
सर,
जब
वो
इंजेक्टेबल थेरेपीज की बात होती है, इंसुलिन से पहले एक और चीज होती है. हाँ बेटे देखिए, मानू ने हाथ कर किया. GLP-1 receptor. I think GLP-1 receptor agonists in an ideal world would be preferred over insulin because they extend cardiovascular and renal benefits. But they're very, very expensive. Average 20,000 per month cost. So I think depending upon patient's pocket, you would decide. Insulin is the ultimate thing. I would rather give insulin because Hba1c I would consider if she can comfortably afford without compromising her other life budgets. Thank you. एक बंदा पछाड़ दो, बस आखिरी केस है. एक बंदा ढूंढ के ला दो मुझे. I think there should be some prize for these guys. Those who came here. No, there's going to be some prize. Whatever that prize is, whoever comes here is going to be some prize. Volunteer. बैसादी आप पहचानने को बंदा, कोई बंदा पहचान के दे मुझे. This is the last one. All right. Case scenario 5. A 34 years old female has been diagnosed with type 2 diabetes and has come to you for a follow-up. She is 34 and type 2 diabetes. Her reports are as follows. CBC HB 10.2 grams per deciliter, MCV 65 as against 78 to 98, and RDW is 12, which is normal. Okay, this is hypochromic microcytic anemia with narrow RDW. That might give you a clue. Glucose parameter, fasting sugar 190, blood sugar random 270, A1C 6%. All right. serum iron studies within normal limits, creatinine 0.6, no renal disease, and albuminuria nil. Okay, so this patient has got hypochromic microcytic anemia, but iron deficiency has been ruled out, kidney disease has been ruled out. A1C is 6%, blood sugar fasting 190, blood sugar random 270. How do you interpret her Hba1c? With such high glucose value, the reasonably good A1c, how do you explain this disparity?
Sir, RBC count is lower. That may be the reason that Hba1c is less. However, since glucose is raised, he is
ये
diabetic.
hypochromic microcytic picture iron deficiency के अलावा किस condition में होती है?
Sir, iron deficiency.
Iron deficiency के अलावा hypochromic microcytic fairly common condition.
Thalassemia, sickle cell.
है, जी।
आपने कहा था जो सही जवाब देगा उसको इनाम मिलेगा।
हाँ जी।
इसको अब जुर्माना होगा।
मैं इसने गलत जवाब नहीं दिया।
ये जवाब ही नहीं
हाँ तो ना देने का तो
Sickle cell anemia.
न सिकल सेल नहीं, ये सिंपल थैलासीमिया है और बीटा थैलासीमिया होगा। पाकिस्तान में बीटा थैलासीमिया कॉमन है, बेटा थैलासीमिया मेजर है। और हाउ विल यू असेस हर लॉन्ग टर्म ग्लूकोज कंट्रोल, जो कि A1C इतनी रिलायबल नहीं है, इसका और तरीका क्या हो सकता है? ग्लूकोज टेस्ट करते जाओ या फ्रुक्टोसामिन कर लो।
Yes, sir. Right.
ठीक है, चलो, थैंक यू। So I've done with all the 5 agenda items. Summary. जी। मैं ये करना नहीं समरी फिर सवाल ले दो। अच्छा, समरी में ये है जी कि Hba1c is a great tool with some important caveats. 6.5 से ज़्यादा हो तो डायबिटीज़ है और एम है टू ब्रिंग इट डाउन टू 7 एंड सेफ जोन है 6.5 से 7 तक. Once somebody is diabetic, it is literally impossible to make him normal, despite all sophisticated tools and so many medications. Diabetic control is a compromise, but we want to achieve the best glucose control with acceptable risk factors. So 6.5 and 7 is, I think, reasonably safe you can achieve. Thank you very much. जी मैडम. हाँ जी, इधर आ जाए.
There is one more scenario, a person with long-standing diabetes and on oral hypoglycemics, having fasting blood plasma level, plasma glucose levels 135 to 40, 135 to 140, post meal, 2 hour post meal is 100, maybe even less. तो उसको क्या मेडिकेशन चेंज करना चाहिए?
A1C कितनी है?
A1C is 6.2.
आई थिंक ये जो इम्पेयर्ड फास्टिक ग्लूकोज है ये एक बड़ा कॉमन फिनोमिनन है. इसके अंदर कई तरह की एक्सप्लेनेशंस हैं. डॉन फिनोमिनन है और वो दूसरा कौन सा होता है? हाँ, सोमोगाई है, बट सोमोगाई इज प्रॉब्ली मच रेयर देन ऑफ टॉक्ड अबाउट. डॉन फिनोमिनन इज कॉमन. एक ये चीज़ होती है जब हम सोते हैं ना, स्लीप इंडक्शन के बाद बहुत सारे हार्मोन्स रिलीज होते हैं. ग्रोथ हार्मोन है, कॉर्टिसोल है, अर्ली मॉर्निंग होते हैं, उसकी वजह से वो इफेक्ट होता है. तो कई दफ़ा हमें कॉम्प्रोमाइज़ करना पड़ता है. अगरचे मेरे ख्याल में अगर TZDs रात को ऐड कर दी जाए तो दैट माइट रिजॉल्व दिस सोल्यूशन, लेकिन मेनी टाइम्स वी हैव टू एक्सेप्ट हायर फास्टिंग ग्लूकोज. द रेस्ट ऑफ द ग्लूकोज इज नॉर्मल, A1C इज ओके, बट फास्टिंग शुगर रिमेन्स हाई. We can't push up with medication at night also. सल्फोनिलयूरिया बहुत देंगे, नॉक्टर्नल हाइपो हो जाएगा. सो कई दफ़ा हमें एक्सेप्ट करना पड़ता है. थैंक यू सर. Are there any questions from the attendees? Any question from the younger lot? Aftab Mohsin is going to ask a question because he always want to believe that he is a young man. नहीं क्वेश्चन ठीक है अच्छा